My talk, it's quite a complex and long one. I'll try to condense all the information, and I just wanted to start by saying that I'm a clear example of the multidisciplinary approach, because when I was a resident, I was sent from my boss to Dr. Ronco's unit. I was working in an ICU, and he is working into the nephrology ward. So the idea was exactly that, to combine the experiences of the two disciplines in order to have expertise in both of them. I will try to give you some, let's say, pragmatic messages, but I will show you some literature currently existing in this topic. The first message is that we tend to overlap the nomenclature of indication and timing. And in my view, but this is a personal opinion, and I'll show you why this is personal, I could differentiate indication from timing. And the indication is the clinical parameter or clinical picture that indicates the start of RRT, whereas I think that timing is the temporal gap that occurs between the indication once it has been reached and the actual start of the treatment. So now I know that the patient requires RRT, but probably it is 3 a.m. in the morning, and I know that before 8 a.m. I will not be able to start a treatment, and this gap might be differentiate indication and timing, probably. Another important note that I wanted to, probably I'm just continuing the messages that Claudio has just given to you, that we will be able to find the exact perfect timing, the exact perfect dose, the perfect machine, the perfect filter, but we should never forget that RRT is a bridge, and we try to support the patient to recovery of his clinical conditions, and perfect dialysis in the context of an inadequate or ineffective overall care. So we have to know, to understand the patient in the holistic clinical context, and that's why there cannot exist a nephrologist who only takes care of the kidneys of the single patient, and an ICU clinician who just say, okay, I'm for the lungs or for the heart, the kidneys are yours, just go ahead. We have to consider the patient in the overall care. However, just going forward, we know that these guidelines are currently our it's not working. Guide, okay, they are published in AKI in 2012, and they're free for download. So I suggest you to have one of these article and tools in your. I'm sorry, like that. Okay, they classified clearly AKI, trying to reconcile all the classification. I won't underline this. And according to KDIGO guidelines, some messages about indication of RRT are present, and they tend to separate some application of renal replacement, the so-called renal replacement, in case, for example, of life-threatening conditions, very clear, if you have hyperkalemia or severe acidemia or pulmonary edema or stuff like that, it is clear that you have to start an RRT, especially in the context of an oligoanuric patient. They also suggest that there is another concept, there is Reynolds Support, and I'll show you what this means. That is to try to anticipate things, to be a little bit proactive, and to see if you are able to examine the patient in a clinical context, you know when the patient is going to have volume overload, for example, or in the case of a congestive heart failure patient is going to have pulmonary edema. So in this case, you have to support the patient and start RRT proactively. as a matter of fact, as Dr. Ronco was saying, they are not giving us any number, any threshold, any clear indication, probably because there are no numbers to give in this topic. I wanted to just give you a sentence that was stated by a pediatric nephrologist with a great sense of good sense, and he's saying that the true indication for renal replacement therapy is the inability to deliver adequate nutrition, adequate antibiotics, and to keep the patient euvolemic. Probably these three messages are among the most important things to first have in mind when you have an oligoanuric patient with AKI. But if you wanted to go more into the topic, you could download this interesting paper by the group of Dr. Ronco. Dina Cruz was the first author, and they tried to design an algorithm in order to give clinicians some flow charts in order to be followed in case of an ICU patient with acute kidney injury. And they started by saying that there are absolute indications, as I was telling to you, and clearly we can all agree that uremic complications, even if we don't see them frequently in the acute patients, some levels of urea, hyperkalemia, problem with electrolytes, and organ edema, like pulmonary edema, are probably considered emergent indications. And especially if you have more than one of these, you probably can be sure that RRT is indicated in these patients. I'm sorry, I'm going in the wrong direction. But then you can go forward and keep examining your patient. And another important thing that is coming clearer and clearer in this setting is the concept of volume resuscitation. We very well know that especially in the first hours and days of ICU admission of critically ill adult and pediatric patients, you have to optimize mean arterial pressure, and many clinicians start by infusing liters of intravascular volume resuscitation. And this is not conceptually wrong, but it must be kept with careful attention. For example, Dr. Goldstein, who is another pediatric nephrologist, forgive me for my pediatric setting, but this is very important example. Every time he's called into an ICU to make a consultation, the first information he wants to have, and probably he wants this information before going to the ICU, is the percentage of volume overload of the patient. So this is the first thing he wants to rely on, just to give you an idea of how important it is. And I wanted to show you this study that is published by a European multicentric community, driven again by the Vicenza group, that it's a very important study with a lot of important messages, very pragmatic, observational studies on incidence of AKI and the application of RRT in critically ill patients. More than 1,700 patients, and one of the most important messages is how strong is the correlation between the fluid overload of these patients and their mortality. So please keep into careful attention. Every single drop of fluid is given to these patients because the mortality is associated with fluid overload. But then they keep analyzing this aspect in this paper, and they realize that obviously fluid overload is an issue in patients who are already receiving renal replacement therapy, but not only in these patients, also in AKI patients, probably because they're not able to manage the fluids, And interestingly, also in patients without any renal issue, probably these are the patients where the timing issue is so important, because we might try to be proactive and to avoid that the condition worsens further. Another important, very important message of this study is the trajectory of fluid overload. You can see here these 3 patients, which are very different. For example, these 2 have a different level of fluid overload that is reached in the same amount of time, whereas these 2 have the same level of fluid overload that is reached in different amount of time. And in this case, probably this patient number 3 is the worst one, because the increase in fluid accumulation is so quick, and this is the patient where probably my action has to be more and more active. And you can see from these calculations that this aspect is independently associated with overall patient survival. Then, if you have looked at the emergent conditions, and if you have taken a look at the hemodynamic stability of the patient and his fluid overload, and still you are uncertain, you can go ahead and just look at so-called mitigating circumstances, again, worsening conditions and facts like severe sepsis. And so you start adding pieces to the overall context of your patient, and consider that if one of these or more than one of these are present in a patient who is decreasing the urine output and is starting accumulating fluids, this might be indication to start. In the same light, you can also consider the so-called non-renal indication. Again, these are cases not actually accepted by randomized controlled trial in order to start a renal replacement therapy if you have no renal insufficiency, for example, refractory septic shock or acute liver failure. You're not really encouraged to start RRT very early in these patients if you don't have any sign of acute kidney injury, but you have to consider these aspects, because you might be preparing to start in case the renal function of this patient is worsening. So the point is that literature is assessing timing, actually, not really the indication, but this is probably just a nomenclature issue. But again, as Dr. Ronco was already saying earlier, the timing definition is not available today, because we don't know if timing is the time to reach the therapeutic target or the time elapsed from indication or whatever. So there are a lot of studies, a lot of retrospective studies, a lot of meta-analysis that are mixing different conditions, different patients, and the score between them is almost even, because some say that early is better, some say that late or even nothing is better, and we don't know exactly what's going on in this field. So there are at least 3 groups that attempted to focus into this issue with a very formal and randomized control methodology. And the first was Dr. Voald from a Canadian group, who started with a feasibility study. They tried it the very first time to see if it is actually possible to select a patient and then randomize this patient into, okay, I need to start very soon, or okay, I force the patient to wait for the RRT and I don't want to start before at least other 24 hours. And they actually succeeded, because they were able to find a population very similar, 2 very similar groups that were actually randomized into starting after 7 hours from the indication where we reached, and the other group after 31 hours, let's see, though, what happened. These are the conditions. So presence of a severe AKI, twofold increase, urine output, some biomarkers, absence of urgent indications. This is very important because we are not dealing with the patient who is choking with pulmonary edema, refractory to diuretics, and who is anuric and fluid overloaded. This is clearly an urgent patient. This patient will never be randomized. So we are talking about a different class, intermediate severity patient, where probably we have to understand what the timing is doing. Again, in this study, this is very interesting to me because they give us some pragmatic information. To accept the randomization, the patient had to be considered enrollable by both the nephrologist and the intensivist who had the patient in charge, and they had to agree that the patient could reliably wait or start very early. So again, if you see after all of this reasoning, they screened more than 1,800 patients, and they ended up with 100 patients. So a lot of endeavor, a lot of effort to do this, a lot of patients that had to be excluded during the way, and a lot of patients that after they were enrolled in the late arm, this is one of the main aspects of all these studies, they ended up without starting RRT because just by waiting, they recovered the urine output, and so they were not indicated anymore to start RRT. So as you can see, they were very good in differentiating the two populations, but this is, again, very peculiar population. Another important aspect to me is that whatever you consider about being early in this kind of patients, you can be sure to be safe because no severe adverse events were not different in the two groups. And again, even if very few people were enrolled, the mortality is in favor of early. This group is currently doing the actual study. That was a feasibility one. The actual study planned to enroll more than 2,800 patients. And the idea is to give a definitive answer to this issue. They are at half of their pathway. And this, if you want to just go to this link and ask for participating to this study, everyone can be enrolled and can enter this study. In the meantime, there are two concluded ones: the so-called Elaine trial that comes from Germany and the AKI trial from France. These two studies are very different in everything: methodology, case mix, indications, timing, and results, as you can see. In the German study, they compared the RT applied to KDIGO stage 2 patients, so very, very early in the AKI severity stage, versus KDIGO 3 plus one of these. So easy patients, let's say less severe ones, trying to anticipating the evolution of KDIGO stage 2 versus something very more severe. And the France study, who compared the two KDIGO stage 3 patients, but in this case, you needed to have some other clinical parameters to start. The indications were different, but still the timing was different, because in the German study, you have to reach a different indication and start within 8 hours. In the delayed arm, you have most severe patient and start after 12 hours. In the France trial, differently, you start as soon as the indication is reached in both groups, but the indication was different. So again, differences in most every part of the study. And the results are different. In German study is very encouraging because the survival of, even the graph is different. They compared survival and here they compared mortality. I don't know what triggers this choice, but however, in the German one, the early group had a much improved, significantly improved survival with respect to the late arm. Whereas in the France group, no difference between early and late was showed. So now we are in a little bit of confusion because we don't know how to rely in which result to rely at the end. The comments are multiple. You can find a lot of editorials trying to reconcile of these results. The important thing to be aware of at this moment is that probably these two studies were not adequately sampled, and that's why we're waiting eagerly the results from the Canadian group, because more than 2,800 patients are going to be enrolled. The triggers were different. You see that in the German trial, they probably provided RRT to less severely ill patients. Probably a lot of them didn't actually require an RRT. And the case mixes were different in the German trial. A lot of cardiac surgery patients, post-operative cardiac surgery patients were enrolled. And again, precision medicine probably is suggesting us that there are specific groups of patients, for example, cardiac surgery ones, who actually benefit from a proactive start much more than the general ICU patients. Interestingly, both groups already published some post-hoc analysis of these studies. For example, the France tried to see what happened about early and late in different populations, septic shock, ARDS, IR SAPS, IR SOFA, and the results is always the same. But interestingly, they say that the recovery of urine output was much better in the delayed arm. So if you try to wait a little bit in this kind of intermediate ICU general patients, probably you will end up with a better urine output recovery. So if you just wait for some more hours, you have spontaneous urine output recovery, but still, even if you start RRT in the delayed arm, you tend to recover more urine output. This is very interesting to me. Again, the German people conducted a post-hoc analysis after 12 months, and they are telling us that in their probably peculiar population made mostly by post-cardiac surgical patients, after 1 year, again, people who were enrolled in the early arm had a better outcome, a better overall survival, and mostly all of the outcomes were better in these populations. So probably a specific population, probably a very good team providing a very safe RRT, but still early in this study was better in probably all of the outcomes. So let's move to, so I gave you some suggestion, probably some confusion about when to start, and at the moment, the only good sense way of interpreting these studies is that RRT, especially in well-skilled groups, is safe. There are a group of patients where there is no doubt you have to start. There is a group of patients where probably to wait a little bit might be an issue, okay? However, there is equipoise at the moment about the two ways of school of thought, ways of thinking. Probably we have something more clear about when to stop, even if GAIDIGO guidelines are about a little bit obvious on this. They say that you can discontinue RRT when it is no longer required. This is very wise suggestion, and we thank GAIDIGO to tell this to us. And importantly, diuretics are not recommended to enhance kidney function recovery. So I will keep back on this. Do not force recovery, just wait for urine output. There is a post-hoc analysis, again, from a very well-conducted observational pragmatic trial, the so-called BEST kidney. They had analyzed about 1,000 patients worldwide, and what they found was that the success group, so those who stopped RRT for more than 7 days successfully, so with an adequate urine output recovered, were those who had a urine output starting again with the volume of about 400 milliliters per 24 hours. So when you have during RRT the urine output that comes out again, and you go over this amount for the first 24 hours, you probably may attempt to stop the RRT and try to see what happens, because probably this patient has a high chance of having recovered renal function and not needing any more RRT. Interestingly, other than urine output, they found also that previous history of increased creatinine in chronic kidney disease were negatively correlated to renal recovery, and that after probably 2 or 3 weeks, most of these patients, the surviving ones, were switched to intermittent and chronic dialysis. Another study on the same line gave another interesting information on this, and they have a similar approach, but what they found was that measuring urinary creatinine in those patients who are recovering urine output might be a good idea to see the quality of the urines. And they suggest that if on day 2 of urine output starting again, you find this level of urinary creatinine, you might end up with a success and winning the patient from RRT. My warning is this. I fight about this every time in my unit. There is no winning protocol currently accepted and currently reasonable. My idea is that you have to wait partial renal recovery and try to see if when the treatment stops or clots, you can just stop and wait what happens to your patient. What does not make sense at all is to stop the treatment during anuria just because you're convinced that the treatment itself is blocking the renal recovery. This is not true. This is not confirmed by any medical evidence. And do not force CRRT winning. You have to wait for urine output to appear again, and then you might try to win your patient from RRT. Okay, so I run to my last part of this huge topic that Dimitris gave me. There is CRRT complication. I won't be allowed to talk about all of them. We will talk a little bit about bleeding during the anticoagulation topic. But I wanted to go into one very important technical aspect that is very, which I take care very much in my everyday clinical activity. That is the fluid balance error. In this proof of concept study in vitro, they tried with the machine that were used to clamp the line, the reinfusion line. The technician overrode the alarm, and so what happens that machine for a few minutes ultrafiltered a lot of fluid. Then the clamp was removed, and the machine tried to reinfuse all the fluid that was erroneously ultrafiltered from the patient. So two big shifts of fluid. In first case, negative, and in the second case, positive. And so the first message of the study is that when you override an alarm, you have to look at what is the alarm cause, because if you don't do that, and if you're not trained enough, there might be very important clinical consequences. Then they tried to see what happened after 10 times this alarm was overridden, and they found that there was a fluid error of 400 milliliters in few hours. This is deadly in a pediatric patient. This is probably not useful in an adult patient, considering the importance I just told you about the fluid balance. So please look at your machine and verify. In my unit, every hour, I ask the nurses to verify the difference between the actually ultrafiltered fluid and what is prescribed. And at the end of the day, we try to sum them and see what is the actual difference, and sometimes it might be very important. Fortunately, probably in fourth and fifth generation machines, this issue has been somehow tackled and solved, because these machines are very accurate at this moment, and they have a lot of security safety measures. For example, the PrismaFlex machine, after 10 overridden alarms like that, just stops the treatment and won't allow you to go further. You have to reinfuse the blood and start the treatment again. So this is very much accurate in terms of safety. Again, just let me touch upon the pediatric setting. You see that the Carpe Diem machine that Dr. Ronco just touched briefly earlier is obsessive in this aspect, and this machine is so accurate for children that every single gram of different fluid balance versus ultrafiltration that is detected from during the dialytic session is detected from the machine after 4 grams. An alarm comes out. So this is very important. And again, what we realized is that when the machines probably were induced to be in error when they were used inappropriately, in this case, we connected our CVVH to ECMO, and we realized that the error was not given by the size of the patient, but by the fact that the patient was connected to the ECMO. And so again, the inappropriate use or unsafe or unwise use of a perfect machine will not help you if you're not controlling every hour what happening to your machine. So I'm just going to the very last slides by saying that again, fluid removal is an aspect of treatment adequacy, especially when you have a fluid overloaded patients, and you have to be aware about fluid balance errors. And is this exactly as when you have to consider your patient on the trajectory of fluid accumulation, you have to consider the trajectory of fluid removal, because not all the patient can tolerate the same amount of fluid removal. So as again, I mean, it's not the case that Dr. Ronco is my mentor. As he was saying earlier, you have to consider how the patient is refilling, and probably a septic patient has a different refill from a congestive heart failure patient with pulmonary edema. So please control the net ultrafiltration errors, but also control the net ultrafiltration prescription hour by hour in your patients. Just to conclude, and just to give you some very important information that is not present in the study if you don't go and read carefully. This is the US study on intensity, and they found no difference between high intensity and low intensity in terms of mortality, okay? Theoretically speaking, they treated critically ill patients with AKI problems. What is interesting is the difference you realized about net ultrafiltration if you go and stratify patients according to the modality. And IHD intermittent patients had the average net ultrafiltration per day of 2 liters, whereas continuous patients had a net ultrafiltration around 3 liters. So again, probably you cannot find a difference in the overall group of patients, but if you go and see what happened to those who needed fluid removal and were treated by CRRT, probably there you can find a difference in overall outcome of these patients. And the exact same number in the Australian group who only used continuous, again, around 2.5 to 3 liters of net ultrafiltration with continuous therapies. So concluding, there is no evidence that waiting and seeing is either effective or detrimental in terms of patients' mortality. This is a fact. There is no evidence at the moment. However, if you are convinced that there is an indication to start, there is no reason for delaying the treatment, especially if the trajectory of your patient is worsening rapidly. So consider the trajectory. And that's why patients should be evaluated in the clinical context. Urine output is probably so far the main guide for RT winning, and we do not have any other biomarker at the moment, but this might be an interesting field for future research in biomarkers. Fluid balance errors, other than bleeding, are among the most severe occurrences in terms of safety. So even if you are using 4th generation machine, which are pretty much accurate and safe in this light, please be aware of your treatment and follow the machine hour by hour. And with that, I thank you for your attention.
Thank you, Dr. Ricci, for your excellent presentation. Question?